Hello and welcome everyone. Today's presentation is on management strategies for refractory status epilepticus. Refractory status epilepticus is when seizures continue after the administration of first-line treatment, mostly benzodiazepines, and second-line anti-epileptic drugs like phenytoin, valproate, or levetiracetam. Management often requires anesthetics and continuous EEG monitoring. In severe cases, general anesthesia using agents like midazolam, propofol, or ketamine is used. Studies show changes in brain during the prolonged seizure, such as alterations in receptor functions, which may impact the treatment effectiveness. The treatment for different types of refractory status epilepticus will be discussed here. The need for tailored treatment approaches for different subgroups of refractory like convulsive status epilepticus, non-convulsive status epilepticus, and new onset refractory status epilepticus will be discussed. Recent evidence support the use of newer anti-epileptic drugs like levetiracetam and lacosamide for NORS. Approaches beyond these like immunotherapy and ketogenic diets are considered. International guidelines and recommendations have been evolving in the area, and we'll be discussing all these. So, according to the American Epilepsy Society and International League Against Epilepsy, status epilepticus is defined with two critical time points, that is T1 and T2. For tonic-clonic seizures, T1 is 5 minutes, duration beyond which seizures are likely called to be prolonged. The T2 is 30 minutes, beyond which seizures may cause long-term consequences. For focal status epilepticus or absence status, these time points differ and are as of now unknown. Now, non-convulsive status epilepticus diagnosis is more challenging. The Salzburg consensus criteria with high sensitivity and specificity relies on specific electrographic or electroclinical features and EEG changes. The American Clinical Neurophysiology Society has incorporated this criteria, requiring continuous EEG changes indicative of non-convulsive status epilepticus for a minimum of 10 minutes or 20% of a 60-minute recording to make a diagnosis of non-convulsive status. Now, regarding the treatment, there is no consensus on how aggressively to treat this. The principle is time is brain applies over here, suggesting a treatment approach similar to convulsive status epilepticus. Animal studies indicate neuronal damage during prolonged non-convulsive status epilepticus, and clinical studies show increased morbidity and mortality with delayed treatment initiation, and the underlying etiology is a key prognostic factor in non-convulsive status. Regarding NORS and FIRE, NORS is new onset refractory status epilepticus is a severe condition characterized by sudden uncontrollable seizures without an identifiable cause. FIRES is a subset which follows a febrile infection. Now, evidence for NORS treatment comes from case reports and limited studies. Recent consensus recommendations emphasize the importance of differentiating an autoimmune encephalitis case from cryptogenic NORS for treatment and prognostication purposes. Now, how do you manage these two conditions? Management could be in a tertiary care center with a multidisciplinary team. Treatment should be initiated 48 hours, should follow the approach of acute refractory status. Immunotherapy is a key component here, differing from most of the other refractory status epilepticus algorithms. Regarding the ICU management, how are you going to manage them? First is, as usual, assessment of the ABC, that is airway, breathing and circulation. Initial care must focus on basic life support measures. Respiratory failure, cardiac injury markers have to be assessed, and if these are elevated, this often leads to a poor outcome. Now, high dose of non-epileptic drugs or anesthetics can cause respiratory depression. Neurocardiogenic pulmonary edema occurs in up to 1/3 of the cases, adding to the complexity in the management. Infection is a common complication occurring in up to 50% of status epilepticus cases. They are associated with longer status epilepticus duration, the need for mechanical ventilation, poor hospital discharge outcomes, and overall recovery challenges. Prolonged seizures can lead to rhabdomyolysis characterized by muscle breakdown, subsequent release of muscle cell contents into the bloodstream. This condition often leads to further complications like hyperkalemia, hyperphosphatemia, hypocalcemia, and potentially severe acute kidney injury. Now, these drugs can mask the ongoing seizures, that is the non-neuromuscular blocking agents, and they make the EEG monitoring crucial for detecting seizures in the ICU. Therefore, avoiding these drugs is advisable when managing status epilepticus. The importance of continuous EEG is essential when using anesthetics to accurately detect and manage ongoing seizure activity. Now, the decision to perform a tracheal intubation in suspected or confirmed non-convulsive status requires careful consideration. The risk of prolonged intubation and ICU must be balanced against the uncertain benefits of inducing a therapeutic coma. Before resorting to anesthetic induction in non-convulsive status, it is recommended to try non-sedative intravenous second-line anti-epileptic drugs to manage the status. The correct anesthetic options available are midazolam, propofol, phenobarbital, and are primarily given as continuous infusions IV. However, there is no consensus or RCT guiding the selection of these drugs. Ketamine, an NMDA receptor antagonist, is gaining attention for promising alternative due to its different mechanism of action and potential neuroprotective effects. It has shown fewer cardiovascular and respiratory side effects, but has drawbacks like hallucinations and potential of increasing the intracranial pressure. A retrospective study comparing propofol and midazolam showed similar efficacy and side effects. A systematic review showed a high success rate in using ketamine for status epilepticus in both adults as well as children. Studies suggest that ketamine is particularly effective when used as an initial anesthetic agent and has manageable adverse effects. Now, the adverse effects of anesthetic drugs and their monitoring. Each anesthetic comes with a unique side effect consideration which limit the duration of use. The continuous monitoring of lab values and cardiac function is crucial to assess the impact of these drugs. Now, combination therapies like propofol ketamine, midazolam ketamine may have advantages. The duration of anesthetic infusion and the extent of seizure suppression are subjects of debate. The weaning process should aim to reduce the anesthetic after 24 to 48 hours of seizure suppression while adding other non-anesthetic AEDs to prevent the seizure recurrence. The use of volatile anesthetic can be considered as an alternative salvage therapy in super refractory status epilepticus due to the rapid action and easy titration. However, they are limited by the potential of serious adverse effects with prolonged usage and lack of robust evidence in terms of treatment outcomes. Now, traditional AEDs, the guidelines typically recommend phenytoin, valproate, phenobarbital, and levetiracetam for resistant status epilepticus. Now, levetiracetam, recent studies including the RCTs like the ESET have focused on levetiracetam as an established convulsive status epilepticus treatment. These studies generally show comparable effectiveness of levetiracetam to other anti-epileptic agents. Now, a new IV anti-epileptic agent like this lacosamide has been explored in numerous clinical trials for status. It has shown promising results, particularly in preventing seizure recurrence with a better side effect profile compared to the phospheniton. Now, phenobarbital traditionally is a second-line therapy. Its use was initially restricted due to the side effects. However, recent reconsideration of its highlights the high efficacy and the unique GABAergic and anti-glutaminergic properties, making it a viable option for early and established status epilepticus. Megadoses of phenobarbital have been explored in super refractory status, showing successful control in some patients. It reduces the risk of respiratory depression compared to other anesthetic agents, making it a potential treatment of choice in refractory non-convulsive status. The approach to non-convulsive status remains a subject of debate, considering recent evidence favoring intravenous anti-epileptic agents. The third-line therapy in refractory non-convulsive status might lean more towards the additional second-line agents rather than towards anesthetics. Regarding the International Norse Consensus Group 2022 recommendations for its management, the acute phase in the initial 48 hours, the seizures in Norse of the fire should be managed primarily as any other refractory status epilepticus using the AEDs and anesthetics. In the first line immunotherapy, that is within the first 72 hours of the status epilepticus onset, initiating immunotherapy is recommended. This may include treatments such as corticosteroids, intravenous immunoglobulins, therapeutic plasma exchange. However, there are variation in expert opinion on the usage of therapeutic plasma exchange. Now, ketogenic diet and second line immunotherapies. If there is an inadequate response to first line immune treatments, the initiation of a ketogenic diet and second line immunotherapy are advised within the 1 week, particularly for non-infectious NORS and FIRES. The ketogenic diet is believed to engage immune mechanisms potentially evolving into seizure perpetuation. The guidance of the second line immunotherapy. The selection of the second line immunotherapy should be based on suspected underlying cause. Rituximab is recommended in cases where pathogenic antibody is identified and there is a strong suspicion of an autoimmune process. Anakinra and tocilizumab is considered in cryptogenic NORS without clear clinical feature of a specific autoimmune encephalitis syndrome. Absence of clear endorsement of specific treatments, current evidence is insufficient to definitively recommend a particular second-line immunological therapy. So clinical judgment is based on suspected underlying cause to find is very essential. So to summarize, once the patient comes, assess the ABC, monitor the vitals, maintain oxygenation, check the blood glucose and have an IV access. In the first 5 minutes, get the first line AEDs. In the next 20 minutes, go for the second line AEDs. After that, if you think there is still seizures, you can go for EEG monitoring. If after 60 minutes you still find seizures, go for third line anesthetic agents. And after 48 hours, consider adding one more second line anti-epileptic AED to the management. Now, in case of non-convulsive, in 5 to 10 minutes, you can start the first line AEDs. In 20 to 30 minutes, the second line. In 1 hour, add a second line AED, that is IV lancomide, or you can even give a mega dose of phenobarbital. After 24 hours, you can try the third line anesthetic agents. Now, in case of refractory status, after 72 hours, if you still see the patient is having status, the initial immune therapy is IV methylprednisolone or IVIG. If after 7 days you still see that the patient is still having seizures, in children, consider giving a ketogenic diet, or in the second line agent, you can go for immune therapy, that is antibody mediated IV rituximab, or if in cryptogenic, then you can go for tocilizumab. Thank you for your patience.